Well, hello everybody, and welcome to the latest edition of Infection Control Matters. Today, Martin's with me. Hello, Martin.
Hello, Brett. Good to see you again.
And we've got our special guest today, which is Adjunct Assistant Professor Kalisvar Marimuthu, who's a senior consultant in infectious diseases at the National Centre for Infectious Diseases and Tock Hospital in Singapore. And Kalisvar is also a member of the National Infection Control Committee of Singapore, and of relevance to what we're going to be talking about today. He's also a consultant on the Technical Advisory Group for WHO's carbapenem-resistant Enterobacteriaceae guideline. Welcome, Kalisvar.
Hi, thanks, Brett and Martin, for inviting me to your podcast. It's amazing you guys are doing this. It has been very useful and fun for infection control. Thank you.
Oh, thank you. And thanks very much for joining us. And today we're interested to have a chat with you about a paper that you led that recently came out in Nature. And it was titled Whole Genome Sequencing Reveals Hidden Transmission of Carbapenemase Producing Enterobacteriaceae. And I guess maybe we'll kick off, Kalisvar, with just telling us a little bit about why did you do this paper, this piece of work?
So I must say we stumbled onto this problem rather than designed a study to look at this issue. So we have been running together with my co-investigators, Untek, Indu, and Janet, who are all in the paper, and a huge group of people with some friends from overseas, UK and US and all. So we have been running this group, cohort of carbapenemase producing Enterobacteriaceae in Singapore. It's called CAPES. So we started this project when I was still a trainee. As you can see how long it takes to genome sequence 1,000+ isolates.
I do like capes, by the way, because that implies you're all superheroes with the capes. So that's very clever.
Yeah.
Thanks.
A superhero effort to this piece of work as well.
Yeah. Yeah, thank you. Thanks a lot. Yeah, and thanks to the group, obviously. So what we did was we collected all the isolates of CPE from Singapore hospitals, about 80 to 90% Singapore populations being served by these hospitals. So we collected all the isolates and we whole genome sequenced them with lots of funds from here and there. And we thought it would be fun to go to the hospitals. When you are young and naive, your ambitions are bigger and you do not know how difficult it is to do it. So that's what happened to us. So we went to the hospitals with a couple of research assistants and we collected the movements of these patients, to the bed level, and daily, hourly, and hospital-wise. And we built an epi picture on their movement. And we correlated that to the whole genome sequencing data with the idea of seeing how many of these people are transmitting the CPE to each other. And then we moved on to analyze what is the incidence of direct ward transmission. This is what we are calling it in the paper. Mm-hmm. And as both of you know, in infection control, for us, contact tracing is same ward, same place, in most of the same time, same place, in most of the hospitals. So we did that, and we found that there's a big chunk of them who were not in the same ward at the same time, but they came after the index patients have left the hospital. Yeah. Mm-hmm. So, and these are the times when the Sengs, there were lots of papers from Amy Maters and lots of others that Seng can be a reservoir for CPE. So we decided to look more into it. And what we found was very interesting in a sense that when we divided the clonally transmitted bugs into direct ward overlap, indirect ward overlap, and no overlaps, we found that almost 40 to 50% of the patients had no direct ward overlap. They actually went to the geographical location after the index patient had left the ward. Mm. So this is what we call hidden reservoirs. It's not something IPCE finds as transmission as of at least a couple of months back.
So what you're saying there, Kalisvar, is that these isolates were genetically linked, not epidemiologically linked, using traditional infection control practices, or surveillance methods, if you like. And so you then the question comes up, well, what's going on here?
Yeah. So after that, everything is a hypothesis still. We are starting a new study. So this is where the Seng aqueous environment became a hot topic in CPE, as we all know. So we need to investigate this more. Is it inadequate disinfection of medical equipments? Are there scopes? Endoscope procedure was one of the variables we analyzed, and we did not see a cluster there. So our main hypothesis is that is there an aqueous environment and also general hospital environment. So we are looking into it now to see how do we quantify the proportion of patients that are infected as a direct result of acquisition from the environment, and what's the proportion the acquisition is directly from another patient, the neighbor perhaps, or the same room occupant perhaps. So this is what we're doing now. And we don't know where is the hidden reservoir from this study. We just showed that, look, there is this thing that's going on, and let's all investigate what's happening.
That's fascinating, because I guess in first interest, of course, is that it just shows that our traditional approach, I guess, to infection control with that sort of time and place and track and trace, if you like, it probably doesn't cut the mustard here, and shows the value of having genomics to help understand this further. But I guess now, as you say, now you've got all these questions that you need to answer, because it's thrown up this remarkable result, fascinating. And now we go, but why? How? So so you looked at the endoscopes. What there were other things that you looked at to try and rule out at the time? Is there anything you could confidently sort of say, we know it wasn't this and we know it wasn't that, or is still everything up for grabs?
So there were two things, mainly the community overlap. So we mapped these patients to the community, their addresses in Singapore, and we tried to map it to that address to see whether there could be a signal in the community. We don't know what is the community prevalence for CPE. Likely low, it's probably nosocomial mostly, but when we traced the addresses of these patients, we did not see any cluster in the community. So we can confidently say this is probably not a community transmission. And then the other one is the scope. We are quite comfortable to say that when we analyze the data on a population level, we do not see a signal. But we do know the small clusters from scopes that we see every now and then, but it doesn't seem to be contributing to a population level transmission, But there's another interesting thing, Brett, you mentioned, our traditional IPC. The thing is, our traditional IPC is doing what it's supposed to do, actually. So if you see our data, we actually found another interesting factor, which IPC potentially did not know prior to this when we designed our measures, plasmid-mediated transmissions. These plasmids are, I must say, they are really difficult to handle. When we see a clonal transmission, which means the bug and the plasmid are the same, we define them as clonal transmission. If the bug isn't the same or they're not linked, but the plasmid is the same, we consider them as plasmid-mediated transmission. Almost 40 to 50% of the patients have plasmid-mediated transmissions. And our IPC doesn't seem to be addressing the plasmid-mediated transmission, which in all honesty, we were not designing them for that purpose, And we did see a dramatic reduction in clonal transmission when the bidirect ward overlap. So if you see the figure, there's the figure 2.
Yeah.
And in the clonal transmission by direct ward overlap just reduced dramatically in the 5 years of analysis. And that shows our IPC measures were designed to do exactly that. So it's working.
Yeah.
But there are something new for IPC that we need to take care of, I think.
Yeah, that's what I got out of the paper, that traditional IPC is working.
Yeah.
Because you're reducing the clonal transmission, which is the sort of thing that IPC teams will pick up easily. They'll pick up clonal clusters, but you won't necessarily pick up plasmid transmissions until you're much further down the line. And so traditional IPC, it works for clonal, but the plasmid is going to be so much more difficult. And I'm sure you're right about the drains. I also wonder about there are areas in the healthcare environment which are much more difficult to decontaminate routinely. And I'm just thinking of something basic like a bed. I was at the Shea Spring meeting earlier this year, and they showed that the risk of acquiring Clostridium difficile was high if the previous person of the occupant of that bed had been a C. diff case within the previous 6 months. But when you actually look at a bed,
wow,
you almost need a degree in engineering to be able to take them apart to clean them.
Exactly.
Because of the complex nature of a bed. And the cleaners get 5 minutes to clean the bed, but you've actually got to take panels off to get it at the works, because now we have all of these, mechanical profiling beds that make them almost impossible to decontaminate. And I'm sure there's, that's the case for many of our pieces of kit now in the environment, become much more complex. Have you got any ideas about where the reservoirs might be? Because, it's a fascinating paper. That's why we've asked you to come on and talk about it.
I must say we were not surprised, but we were stumped by the findings, because there's the amount of work that we need to do moving forward is just a lot. And Martin, you were absolutely right when you talked about the other parts of the beds. We always talk about high touch surfaces, right? And they're important, definitely important. We all know that, and they seem to be working. But how about low touch surfaces? Have we ever, this is the part where that's hidden, and the dust that may just come up, fly out every now and then,
Yeah.
So what we are doing now is we are actually, as part of this, quantifying the environmental transmission. So we are sampling the aqueous environment. We are swabbing the high touch surfaces, and we are also swabbing the low touch surfaces to see what is the contribution from low touch surfaces. Because Martin, when we go to our management, cost is everything. Even especially in high income countries, cost is everything.
Yeah.
So when we tell them that there's this, yes, and when we go tell them, look, there's this hidden spot here which we need to clean as well. The next question that the people may get is, why do we need to clean that? No one touches the area. But that's not how bugs work.
No. And you do get dissemination from these low-risk areas, though, don't you? I remember a paper from Curtis Donsky's group a couple of years ago now, where he seeded the floor with some bacteriophage, and then just through walking around an aerosol, everything gets re-aerosolized. If it's dry environment, dry dust, it gets re-aerosolized all the time. And there was another recent paper from Vincent Cheng that showed the air counts of Acinetobacter in the period after changing diapers were absolutely huge. And of course, the air doesn't think, okay, I'm just going to deposit these organisms on high-touch surfaces. They go absolutely everywhere, but then they can get re-aerosolized onto other surfaces. So I'm quite interested in the air now. There's a few, there's been hints that actually removing organisms from the air has an effect, but I think we need better studies thinking about that as well.
Yeah, absolutely. And I'm sure, we all have come across this far UV technology, the 222 wavelength UV, which is potentially protective, not harmful for eyes and skin. So these are the technologies we are investigating now for exactly the purpose you mentioned, Martin. Even MRSA, right? Staph aureus, it actually goes in the air. There was a paper before, when the bed sheets are changed in the morning, it actually, floats in the air. It may not linger too long, but it uses the air environment enough to go to the next patient or the few patients down the beds, So yeah, lots of work.
We've talked a lot about trial room occupancy risk. Would there, as part of future work, are you going to explore things like, treatment rooms where there are medications made up, nurses congregating and coming to get different pieces of equipment, things like dressing trolleys, all these types of other bits of equipment and or locations that might be, a place where some of the plasmids are transmitted, and some of these bugs might well be transmitted as well, or at least lingering or acting as a third-party transition. So are you going to, in your future work, it's a big piece of work, because where do you stop? But are you thinking about areas other than just the sort of risk of the last occupant in that near environmental room?
Yeah, I think where to stop is one question. Where to start is another question, isn't it? So we are starting to look at, we're starting from the patient environment, the rooms, which is the aqueous environment, shower, used Hoopman's paper on shower and Pseudomonas transmission. So we're looking at shower, aqueous environment, high touch, low touch areas. And now, Brett, I must say, I never thought about the treatment room before this, so I'm taking down copious notes.
I can always listen to this back.
So yes, exactly. Yeah, so I need to go talk to our infection control nurses. They are the one who knows what's happening everywhere in the wards, and you need to address. Yeah, treatment room, definitely. Yeah. If in a few years back in Singapore, there was a Hep C cluster in one of the hospitals, and it was actually located back to potentially blood stains related to treatment rooms and trolleys. Yeah. Mm-hmm. So that is something we need to look at, definitely.
And then the pieces of equipment that go between patients,
especially the BP machine, Dynamap. It's just so difficult to wipe that thing.
It is.
I'm not sure. I'm amazed at with the way how I don't know how our nurses are doing it. You have a ward full of patients and you have one machine for a cubicle.
No. Do you know? I think a while ago.
Yeah, I came up with a procedure to actually clean a blood pressure cuff. Because it's a big floppy thing. Well, but it's not going to be usable in the real world, because what you'd have to do is wipe a surface, clean a surface first, put it down, wipe one side, lift it up, clean the surface, turn it over, clean the other side. The chances of getting someone to do that between each case, each time you take a blood pressure, is absolutely zero. No, that's right. I even wondered about trying to get a clip you could put on a blood pressure machine so that at least you could pull the cuff taut so that you could actually wipe each side and clean each side, because I asked the manufacturer of the blood pressure cuff, how do you clean it? And they just say, wipe it. And I said, no, how do you clean it? Physically, how do you do it? And they never came back to me. And there's lots of tricky things like that, isn't there?
Yeah.
I mean, one thing that struck me about the paper is you're showing that traditional IPC stops clonal spread. But how well do you know that you're doing traditional IPC? Is your hand hygiene compliance really very high? And is the environment clean very well? But actually, there are things that we think we would class as traditional IPC, like cleaning a room after somebody's gone home. But that is, every paper from Phil Carling says it's not done well. How well do you actually think you're doing traditional IPC? And actually, by improving traditional IPC, could you start to make an impact on the plasmid? Or do you think you've gone as far as you can with traditional IPC and now we've got to think outside the box?
I think we need to think outside the box. The reason is because, when we say traditional IPC, there are two components to it, right? What we need to do and how much of it is being done. I would like to think that our teams are already doing the maximum possible, given the resources, time they have, and ward occupancy. So I think it's a combined factor. So I would think that they have potentially reached unless there's a new technology to do it easier, they probably have reached the maximum possible ability to do the cleaning, I would think. The number of patients are increasing and the number of nurses are not increasing proportionately. Housekeeping, cleaners, cleaning manpower is also may not be increasing proportionately. So I think we need to find new technologies to do this work and also find low-hanging fruits. Where is the high impact area for which bug? For example, Acinetobacter baumannii, when we had a cluster, slightly unrelated to this paper, but, it's dry environment. So when we focused on dry environment, there was another paper, the cartography of microbiome that we did. MRSA, ABAO, and all seems to be more on the dry environment, the bedside. So when we address that seemed to bring it down. But is it sustainable? Is another question, how long can we continue to do this new aggressive intervention? When you stop, the numbers will go back up. So I guess the question to the question of if we have reached the maximum possible of IPC, classical IPC, I think we have. But I don't think is adequate IPC measures for aqueous environment. We know hand hygiene, 5 moments of hand hygiene. And Yes, Martin, everyone will have 90 to 100% energy. Same in Singapore. So,
yeah.
But do we know when are we supposed to clean? How frequently are we supposed to clean the sinks? Why are we not advising this is the frequency you need to change the P-trap? This is how frequently you need to scrub the steel trap, sink trap. So what is the recommendation for this? These are the guidelines that's currently not in. Hospitals do as per their ability and what they feel is adequate for their hospital. But I do think that there needs to be more defined guideline. Am I missing any guideline here? I don't remember seeing any. Do you?
No, I don't remember seeing any. I mean, this is tricky, isn't it? Because the plasmid does make it difficult then, because unless you've got genome sequencing, you're not going to know you've got a plasmid whizzing around in your organisation, and many organisations won't have access to that level of diagnostics. And so how do you spot the outbreak? That's the problem. Yeah,
and the definition of outbreak may need to change for plasmid organisms, the rhizostomes that are transmitted by plasmids. It may not be two similar bugs in a location. Or every weekly meeting, when they find 3 Klebsiella in our ICU, they're all 3 carbapenem resistant, that becomes something that we intervene. But we have 40 to 50% transmission that are plasmid mediated. So should we provide them with genomics results on a weekly basis? But if we do give them, we also need to equip them with the knowledge of what to do with them. It's not intuitive to everyone that, if I get genome results on a weekly basis, whole genome sequencing results for bugs from my ICU, I may not know what to do with them. So we in IPC may need to come up with a guideline on that as well. What do we do with genome results?
Yeah. Yeah, look, one of the things that was crossing my mind as you were talking about this was exactly that. And what surveillance definitions are we going to use to be able to determine outbreak using plasmids? We're going to have to think through this quite a lot. So, thanks, Kalis. You've really you've really created a lot of great questions there you can go and answer from this paper. This is why I found this paper really fascinating.
Yeah, I'm glad you did this for a bit of fun.
So I guess, Kalis, we've had on the past and quite recently Patrick Harris and Belinda Henderson and others come and talk about work they've been doing around whole genome sequencing and trying to get that into everyday IPC practice. Where do you see yourself and your hospital, Singapore more broadly, in terms of future and using genomics to help manage and identify outbreaks? And you talked about perhaps weekly feedback, and then, of course, to work out how it's going to be interpreted. But do you see this as something that can be done in the future quite quickly in with the infrastructures that you've currently got, or is it going to need a bit more investment to track?
Yeah. Patrick Harris and team have been doing excellent work in this field. They are one of the pioneers, and they are doing amazing work. And I do think they are probably investigating something else in the line on what's the impact. So we interestingly, we did an experiment for fun because we had some fund. So we did for fun. We sequenced all our CRABs, carbapenem-resistant A Baumannii, for almost a year. And we gave the results to our infection control unit. We published this in ICHI recently. Infection control unit, we said that, look, our numbers are not going up, but you have ongoing transmission of 4 clones, and they are closely related. There is ongoing transmission. Because of the baseline IPC measures, the horizontal measures, plating, hand hygiene, and all, it's not creating our. And the question we got was, what do I do with data now? I'm not seeing a surge, and you are saying there is a transmission. What does it mean? And then, so we worked them. We had a few meetings, and then I'm in IPC, meaning I gave the results and I asked the questions as well. And eventually we came to the same IPC, genomics, ICU team and all. We said, okay, we're going to select environment for intervention. There's no other way these transmissions happening. We implemented HPV, hydrogen peroxide vaporization, after every CRAB patients, and the numbers came down. So now they are believers in the whole genome sequencing, but they like it. Yeah. So I do think there's a role, but I think the turnaround time will need to be quicker. Currently, it's not quick enough. We need fund to do this kind of work. It's not small. It's very costly, So we need to do that. But I do see this being in the forefront of IPC, at least in some number of hospitals in the next, hopefully 3 to 5 years, but maybe 5 to 10 years.
Yeah.
I mean, even if you don't have access to whole genome sequencing, actually, this paper does give an indication, because if you're seeing a lot of, multi-resistant enterobacteriales around your organization, reading through this paper, you'd be thinking, well, half of it is not traditional clonal transmission. There's a plasmid moving around as well. So maybe you've got to think outside the box like you are doing with your IPC measures, and start thinking about what you're doing with water, what you're doing with air, what you're actually doing with your overall cleaning, other areas that you're missing in your organization. Because if you're only picking up or able to control half of it, the clonal spread, then there are still many challenges out there for us. So I think it's an extremely useful paper for even people who won't have access to whole genome sequencing for quite some time.
I do think that we need a paradigm shift. We talked about paradigm shift in, I don't want to digress, in aerosol droplet field, but I do think we need a paradigm shift in the way how we view environment as a whole in terms of how it affects our patients.
Yeah,
I mean, IPC seniors before us have done lots of work. They've done lots of work, and I think we need to do more work to see how does future IPC, how should it be, in the next 20 to 30 years.
And because we're heading to a period where prevention is going to be better than cure, because we won't have a cure. Anyway, thank you so much for joining us, Kalis. I've really enjoyed this paper. It's, like all great research, it throws up far more questions than answers. But it's giving us directions to travel in that are completely different. So I want to really thank you for joining us today, and thanks to Brett for being able to get on the call as well.
Yeah, thanks, Kalis.
Yeah, thanks for inviting me, and always a pleasure.
Okay, well, I look forward to seeing you in Singapore in a few weeks, and to everybody else, see you on another episode of Infection Control Matters.